the health sector has been long considered to be a welfare activity and not a commercial activity at this stage. So it has been believed earlier that management techniques have no role in running the health services. But recently it has been appreciated that health services, which can range from a government provided health service to a private clinic or a private hospital, the services can be much more efficiently managed if they are effectively planned with the help of modern management techniques. The management techniques which can be used in healthcare can be classified into three types. Qualitative techniques, those are based on the organizational behavior, how to manage better the personnel. These are as follows. They have been covered in part 1 of the lecture. Second classification is quantitative techniques, which are based on economics. These are cost benefit analysis, cost effective analysis, cost accounting, input output analysis as they are applied in healthcare. These four techniques have been covered in part 2, that is this lecture. And the third category is quantitative, that is they are based on budgeting and operational research, and these are as follows, and these have been covered in part 3 of the lecture. Cost benefit analysis. This is done because public funds are never sufficient to cover all the welfare activities. So there is a need for any government to rank various welfare projects so that it can be selected that intervention which would bring the maximum benefit to the population in monetary terms would be given first importance. The others in the rank would be considered when more funds become available or after the first one is complete and we have funds in our hands still left. In cost benefit analysis, the costs are expressed in monetary terms obviously, and the benefits are also expressed in monetary terms. That is, cost is the money which is spent and benefit is the money which is saved by applying the intervention and money earned by the society. We will discuss it in detail. Both the cost and benefits at the time of being analyzed have to be adjusted for inflation. So their values are expressed as the present value. That is the value at the time of analysis being performed. One example can be the policymaker may need to decide if it will be more beneficial with a given budget to tackle indoor air pollution in a district or to implement an HIV screening program. So cost benefit analysis of both the interventions can be done, and the intervention which is shown to have a higher return in terms of money per unit cost would be more apt for implementation at the first go. The steps involved in cost benefit analysis are obviously first computing the cost of implementing the program, and then computing the benefits obtained from the program and converting it into money, and then comparing the cost with benefits. So what we calculate in the end is cost benefit ratio or benefit cost ratio, that is benefit per unit cost. The idea is to demonstrate that even if we don't consider some social importance, some social benefits which cannot be monetized, the program still results in significantly monetary benefits compared to the cost. Now, an example of converting the outcome in terms of money is given below, like preventing HIV. One can compute the monetary value by adding up the average healthcare cost that an HIV patient would require if he becomes HIV positive, the monetary gain of the years of productivity that are saved by him not becoming HIV positive. Then one can estimate how much money the program saves for every rupee that is spent in preventing HIV transmission. we will discuss a hypothetical example of cost benefit analysis. One needs to decide whether it is worthwhile to invest in reduction of indoor air pollution, which is one of the main causes of childhood pneumonia in a developing country. The first step is measuring the cost involved in reducing the indoor air pollution. First would be direct costs of the intervention, and second, don't forget indirect costs are also there. Direct costs are the cost which are the cost of the material, equipment, salaries of the staff, and other overhead costs. For example, laying down gas pipelines. Indoor air pollution main cause is burning firewood or coal. So using cleaner fuels would reduce the indoor air pollution. So laying down gas pipelines, purchasing natural gas, cost of procuring LPG cylinders, cost of transporting them to these villages, cost for developing biogas plants, etc. So following were the costs that were worked out for various, following were the direct costs which were worked out. Then indirect costs. An example of indirect cost is a man who is staying home to get the equipment installed and again staying back to learn the functioning of the new gas stove. This may include lost wages. He is not going to work but staying back. So how do you measure these indirect costs? You need to conduct interviews, doing survey, for example, doing the type of employment in that area which has been foregone, the education status of the population, other data like city bus fares, the minimum wage rate of the area, so that you know what is the cost of lost wages, etc. Now let us say this cost, the indirect cost, came out to be 2500 million rupees for the entire state. So the total cost of reducing indoor air pollution in the state came out to be 6600 million direct cost and 2500 million indirect cost. So total of 9100 million rupees. The next step is calculating the estimated benefits in monetary terms which will be gained by reduction in indoor air pollution. First head, savings in cost of treating childhood pneumonia which were caused by indoor air pollution. So the attributable risks by various studies have been average found to be 40%. So if the target population has an incidence of 400 per 1000 under 5 children and the attributable risk is 40%, we calculate that it will save around 160 episodes for per 1000 children under 5 of age in the area. And then we calculate the expenditure per episode, the average expenditure like doctor, nurse, the time, the medicines, IV fluids, health workers time, etc. Let us say it come out to be rupees 5000 per episode. Hence we save a total of 160 into 5000 rupees per 1000 under 5 population. So if the under 5 population is around 45 million, we save so many million rupees. Then reduction in respiratory infection in women also. We leave more working days with her. Then she will save time which she would have otherwise spent in taking the child for treatment. So she will have more working days in her hand and get more money. Let us say it was calculated to be 400,000, 4 lakh million as per the local wages. And then daily time saving from firewood collection can further be translated into monetary gain of 5 lakh million or 500,000 million. So total monetary gain was calculated to be so much, which was divided by the cost of 9100 million rupees, and the benefit cost ratio came out to be 150. That means for every rupee spent, the country earns a huge 150 rupees. Thus, the decision goes in the favor of investing in a program for reduction in indoor air pollution. And the other 4 which were also suggested had a benefit cost ratio ranging from 5 to 7.9. Then obviously 150 had an upper hand. Now the other options will. Where is cost benefit analysis used? Its uses in healthcare, as we have already discussed. It provides a basis for ranking various projects. Comparing the computed cost of each option against the expected benefit, we calculate the cost benefit ratio, and to determine if an investment is sound in terms of CBR, that is, if there is some funding agency, then to show them that their fund is well utilized. What are the advantages of cost benefit analysis? It allows the comparison of outcomes between two policies with different outcomes. For example, if you have limited resources, then whether to invest on reduction in under 5 pneumonia or to invest on screening program for early detection of cervical cancer. So the cost benefit analysis would be done for each of the two, and the one with the higher benefit per unit cost will be selected for further consideration for implementation. Second advantage is it can account for all the possible outcomes. That is, all the possible outcomes can be expressed in monetary terms and then translated into the benefits. So advantage is when the outcomes of two schemes are different, they can be compared because both of them are converted into money. Second advantage we discussed is that all the outcomes can be considered at one time, because again each outcome is converted into money. What are the disadvantages? Is that all the benefits of an intervention cannot be converted into monetary benefits. For example, social benefits. In this circumstance, when the benefit intended cannot be converted into money, then cost benefit analysis is not useful. Second limitation is the data collection is complex because we need to see the cost for all the benefits. All the benefits cannot be converted also, plus you have to go around doing survey, interviews, seeing various wages. So data collection is complex. Cost effective analysis. This is usually comes after once a welfare policy has been selected after cost benefit analysis. Then various ways of achieving that defined result of the intervention are analyzed, and it is decided which way is the least expensive for attaining that result. Hence, the output is measured in terms of results, that is health units that you want to attain and not money. So cost effective analysis involves choosing one among different possible ways of achieving the desired health result. For example, as in the previous example, it was calculated that reduction in indoor air pollution would result in the greatest economic benefits after cost benefit analysis. Now, various possible ways of achieving the reduction in indoor air pollution are to be analyzed per unit cost, will give cost effective analysis, and the one which is most effective, that method would be chosen. Cost effective analysis can be used even still lower levels. For example, at the last level, when we are decided upon biogas plant, then which model of biogas plant is more number can be given for 1000 rupees. So it can be used at a still lower level. Other examples of cost effective analysis is number of households with reduced air pollution per 1000 rupees, or number of children immunized per 1000 rupees spent. The most commonly used outcome is number of DALIs, that is disability adjusted life years gained per unit cost, because it reflects a weighted combination of both deaths and morbidity due to the condition. So these effects are reflected in DALIs. So this is the most commonly used outcome. So number of DALIs gained per unit cost. Other possible outcomes can be cost per life saved, or number of life saved per unit cost for different treatments for the same ailment. Sometimes a population model may be required. As we discussed before, a population model may need to be constructed for accurate estimation of the effectiveness. That is, what percentage of the population are educated enough to listen to you, how many of them would actually allow you to enter their homes, how many of them would do as you instruct them, how many of them will carry your instructions around and motivate other people also. So this a population model is required to check how it will function Here is an example of cost-effective analysis. Again, this is a hypothetical example when we are comparing two approaches for conducting an immunization clinic, and we calculate their cost effectiveness of each. First approach is that the health worker of the local area makes house-to-house visits and reminds to bring the child for immunization. Now we can estimate, depending upon the response of the people and the interview of the health workers, we estimate that 43 kids would attend the immunization clinic. Another approach, that we send mass SMS reminding them to attend the immunization clinic. Now we estimate how many are likely to attend, that is how many of the women are educated enough to read the SMS, how many of them actually own an individual phone. So after considering all this, we estimated that 31 kids would attend the immunization clinic. The next step is to calculate the cost of each approach. Now remember, then when you calculate the cost, every cost should be included. For example, cost of the time that is spent, cost of the transport of health workers, etc. So let us say this total cost of house-to-house visits came out to be rupees 3,500, and the total cost of SMS was rupees 700. Now we divide the total cost of house-to-house visits with the total number of mothers who were calculated to attend immunization clinic, and we calculate the cost of SMS messages by the total number of mothers who brought the child to immunization clinic. So house-to-house visits resulted in 3,500 cost by 43 kids who would attend the clinic, that is rupees 83.4 per child. Whereas the mass SMS cost was 700 divided by 31 kids estimated to visit us and was 22.6 rupees per child. So in this hypothetical example, the SMS were found to be more cost effective compared to house-to-house outreach. So often for this calculation, one again may need to build a population model instead of actually carrying out the study. That is how many households, as we discussed above, have cell phones, cost of the service providers, the literacy rate, etc. Now extending our previous example of cost-benefit analysis, once it was decided that we need to decrease the indoor air pollutions in the area, cost-effective analysis was done to compare various type of clean fuels which can be provided. So following were the fuels considered: kerosene, LPG, PNG, electric stoves. The population model, considering the total number of household composition, types of houses, their socio-economic status, education status, etc., was constructed, and various studies have shown that these many dalis are gained if LPG is used, kerosene, etc., etc., etc. The use of electricity was found to save the maximum number of dalis. Now the cost of biogas plant was similar in both urban and rural areas, but in the urban areas only a few pockets existed where the environment was conducive to build a biogas plant. That is, number of the cattle was there, and people were open to use biogas. There was a place to make a biogas plant. So only a few areas existed where this was available. But in rural areas, almost 95% household would be covered if biogas plants are built. In rural areas, it was calculated that for every 1,000 rupees invested in LPG would save around 51,000 dalis per district. 1,000 rupees in biogas would add around 75,000. The electricity, which is the most clean fuel and adds the most dalis in ideal conditions, could save only 100 dalis, because electricity the cost was found to be prohibitive. It was seen that the people in rural areas would not use electricity for cooking in any circumstance. So in actuality, only 100 dalis were added. In urban areas, it was found that LPG and gas pipeline would save 91,000 dalis per 1,000 rupees investment, and biogas will save only 15,000 dalis, because only few pockets exist which can actually use biogas. And again for electricity, only around $5,000 were added per thousand investment, because electricity is again too prohibitively expensive for urban residents also. So it was seen that the cost of covering urban population with LPG and gas pipeline was much lower as the cost of covering a village with these LPG and gas pipeline. So it was decided that biogas plants are more cost effective in rural areas, whereas LPG and gas pipeline are more cost effective in urban areas. Uses of cost effective analysis. As we discussed, for selecting the most efficient intervention for achieving the objectives, because CE estimates the cost and health gains of the alternative interventions. Second use, for evaluation of various activities under a program. When you evaluate the functioning of a program, we can compare the cost effectiveness of the existing intervention with a new intervention or other interventions which can be done instead of this. So a decision to continue or replace the intervention can then be done. Advantages of cost-effective analysis. Advantage is that it is easier to calculate than cost-benefit ratio, because less information is required. We just need to know the number of results and compare it to the cost, and then calculate the cost-effectiveness ratio. We don't need a population model for converting the results into money. So it is easier. The limitation of cost-effective analysis is that it doesn't make comparison between two interventions which have different outcomes, because we cannot compare apples with oranges. So it can only be used for ranking those interventions which produce a common outcome, since it does not state if the benefits exceed the costs. This table shows the differences between cost benefit and cost effective analysis. Very commonly asked question. The outcome measured in cost benefit analysis is the money which is gained. So all the outcomes are converted into money. The outcome measured in cost effective analysis is the health units like DALIs or number of lives saved. Indices which are calculated in cost benefit analysis is cost benefit ratio, where it is health units per unit cost. Use in healthcare. Cost benefit analysis is used at a higher level, at executive level, that is, we are considering different proposals. So at the decision making level, for example, ranking various interventions in the budget of health sector, whereas cost effective analysis is used at a little lower level, like selecting the most effective intervention for the outcome which has been defined, or for evaluation of activities occurring under a program. Other differences are, cost benefit analysis can be used to evaluate public expenditure programs which are aimed with different outcomes, even different sectors, that is, we should invest the money that we have in education sector or health sector. So different outcomes can be compared because all the outcomes are converted into money. Whereas cost effective analysis, this cannot be done. We cannot compare activities which have different outcomes. Second difference is every health benefit is not measurable in terms of money. In these cases, cost benefit analysis cannot be done. Whereas when the health benefit cannot be converted into monetary terms, cost effective analysis can still be done. Third, cost benefit analysis is comparatively more complex, because you have to create a population model wherein you have to convert every activity into money. So the data collection is very complex. So CBA is more complex, whereas cost effective analysis is relatively easier, because you just need to know the number of effects, number of DALIs, number of lives saved, etc. Cost accounting. What is cost accounting? Cost accounting is the process when we classify the cost of any healthcare activity and estimate the cost under various heads by governments or even at lower organizations. The costs are categorized under various heads like salary, material cost, radiology cost, canteen, allied services for visitors, burden cost, which include rent, water, electricity, etc. So once the costs are calculated under each head, the organization can determine which costs can be reduced. For example, a hospital replaced free medical care, which was very expensive, by paying the annual premium of the health insurance of its employees. At the government level, some screening procedures were found to be not required for the whole population but for a high risk approach, replaced by high risk approach. Even at a private hospital level, the margins can be optimized by identifying the source of largest cost. For example, the cost accounting of one large hospital revealed that the hospital was losing money on account of low reimbursement rates by various agencies. So the old contracts were cancelled and new contracts were signed with higher reimbursement rates. In this case, the agencies knew that they are giving low reimbursement rates, but they continued. It suited them. But when cost accounting was done, it was found that this was the major source of loss. So various uses of cost accounting in healthcare is cost control, as we discussed above, planning and allocation of resources, which requires more resource, and calculating the price of reimbursement, as was done in the given example. Input-output analysis. This is a tool for analyzing the interaction between different sectors of an economy of a country. A model is made, which is called matrix, depending upon the intersectoral interactions. So this can aid in optimizing the planning of public health policy. So what happens when the interaction between different sectors is analyzed in a given population? It leads to creation of a model called input-output matrices or tables. You can use the input-output matrices. One can estimate if you change the input in a sector, what will be the change in output? Or for every unit of output that is required, what changes need to be put in the input? So both ways it can be used. In case of health sector, the inputs are in terms of money, manpower, material and time, and the output can be anything like number of lives saved, number of vaccinations given, number of cases treated, etc. The main function of input-output analysis is to evaluate a sector's requirement for meeting a certain demand. For example, if you want to increase the immunization coverage, what inputs do we need to give? And withdrawing from which sector and putting in this can be used in input-output matrix.